This video will discuss about the tips and tricks for lens sparing vitrectomy in stage 4 and 5 ROP. The indications for lens sparing vitrectomy include stage 4A ROP with progressive traction, threatening macula despite adequate laser to the peripheral avascular retina, acute vascularly active stage 4B ROP with risk of further progression, and stage 5 ROP without retrolental fibroplasia. Irrespective of the stage of ROP, the main prerequisite for performing lens-sparing vitrectomy is the presence of adequate surgical space between lens and the anteriorly displaced retina. Lens-sparing vitrectomy for ROP needs modification in various steps of conventional vitrectomy compared to the same in adult eye due to high risk of inadvertent injury to lens or retina. We need to understand various factors which increase the risk for such injuries, including anatomical factors, instrument-related factors and disease-related factor. First of all, anatomy of infant eye is significantly different from adult eye with shorter axial length, relatively large globular lens, and short pars plana. The second factor is related to the readily available instruments which are meant for VR surgery in adult eyes. The length of trocar is 8 mm, while the length of the intraocular part of cannula is 4 mm. These relatively longer instruments increase the risk of retinal injury in infant eyes. And the third factor is the disease itself, where the peripheral retina is anteriorly displaced, compromising the surgical space in stage 4 and 5 ROP. So, the first modification we need to make is to reduce the distance of sclerotomies from the limbus due to shorter pars plana in infant eyes. In infant eyes, the ports are placed at only 1.5 mm posterior to the limbus. The second modification in lens-sparing vitrectomy is the modified entry of trocar and cannula to compensate the instrument-related factor. Various techniques including stop and slide technique, and spacer technique have been described. In stop and slide technique, once the initial part of cannula engages partly into the sclera, a forceps is used to push the cannula inside further, while the trocar is withdrawn from there itself. This way, shorter length of trocar enters the eye, reducing the risk of retinal injury. This short video shows stop and slide technique of trocar and cannula entry. In spacer technique of modified trocar cannula entry, a spacer is used under the hub of cannula, thus reducing the length of trocar entering the eye, and hence reducing the risk of retinal injury. A spacer is created by cutting a 2 mm wide end of 42 silicon band, and then bisecting it into smaller 2 into 2 mm squares. Each trocar and cannula is pierced through the silicon piece, holding it with a toothed forceps, till the hub of the cannula. Other advantages of this technique include reduced risk of lens injury and easier cutting of anterior vitreous due to the shorter length of cannula in the eye. This short clip shows the spacer technique of trocar cannula entry. However, surgeon needs to be careful while taking out the instruments during surgery, as the cannulas with spacer can come out easily. Also, in this technique, there is risk of slippage of infusion to the suprachoroidal space. Hence, I personally use the combination of these two techniques. I use the stop and slide technique for the cannula meant for infusion line, and the spacer technique for the rest two cannulas. The next point we need to consider is the selection of right quadrants for the placement of ports depending upon the configuration of anteriorly displaced retina. If temporal retina is not much anteriorly pulled up, a conventional 3-port approach should be adopted, in which the first port is placed in inferotemporal quadrant used to connect infusion cannula, while 2 superior ports are used for surgical maneuver. Here, the surgeon sits toward the head end of the patient. But, if temporal retina is pulled up very close to the lens, in such cases it is better to adopt all-nasal approach, in which all 3 ports are placed in a nasal half. The infusion is connected to the middle one, while other 2 are used for light source and vitrectomy cutter. The surgeon sits on the side of opposite eye. Here you can see the actual image showing the position ports in conventional as well as all-nasal approach. In the later, the infusion is connected to middle port. This clip shows placement of 3 ports in all-nasal approach using combined technique of modified trocar cannula entry. The aim of vitrectomy in ROP is to identify all tractional bands and to dissect them properly. This is the video of lens-sparing vitrectomy performed for stage 4A ROP, in which progressive traction started threatening macula despite adequate laser to the peripheral avascular retina. As the peripheral retina was not much anteriorly pulled up, a conventional 3-port approach was adopted. Entire vitrectomy is performed using shave mode setting with low suction. One should not attempt to induce PVD. There is no need to peel membrane as it's difficult to differentiate between vascularized membrane and retina, and hence can result in retinal tear. Vitrectomy should be limited enough to release all the tractions. If vitreous hemorrhage is close to retina, it is better to leave as hemorrhage will clear spontaneously. Laser can be done to the peripheral avascular retina if feasible. Fluid air exchange should be performed before closing the case. If any sclerotomy is leaking, it is better to suture because postoperative hypotony can cause vitreous hemorrhage. A timely intervention in the form of lens-sparing vitrectomy with proper technique can result in very good outcome both anatomically as well as functionally, especially in stage 4A ROP.